In sub-Saharan Africa, severe anemia, which is a hemoglobin below 6, is a very common cause of paediatric admission.
Blood is scarce and therefore you need to transfuse only in the group that need it.
It makes your work very challenging because if there's no blood and you see a child suffering, it's not good.
So this is extremely unusual. So I've worked in clinical trials for 25 years and I've never seen a result this extreme.
Seven-year-old Janie has come to emergency with a severe infection, possibly sepsis, possibly typhoid. She has a fever of 38.7 and is only partly conscious. Most dangerous, she has severe anemia. Without enough red blood cells to supply her body with oxygen, her breathing is laboured. Her hemoglobin, or HB, is just over 4 grams per decilitre, about a third the normal level. This puts her at serious risk.
Children who are admitted with severe anemia have very poor outcomes, not just immediately in their hospital admission, but also the high hidden mortality that we see in the 6 months after admission.
So there are so many causes of low HB.
There's high burden of malaria, there's high burden of HIV.
The malaria parasites, they break the red blood cells. As such, the hemoglobin go down.
Sickle cell.
Nutritional deficiency, anemia.
And there are so many factors that can contribute to it.
There is simply not enough blood donations happening in Africa, and so they have tried to limit the uses of blood. The WHO have made recommendations that not all children who have severe anemia should be transfused. And this is what we believe may have affected some of their poor outcomes.
Current WHO guidelines are based on expert opinion rather than evidence, as no clinical trial has been done. Children with an HB below 4 are recommended to have a blood transfusion of 20 mL per kilo of body weight. But children with an HB between 4 and 6 are not recommended to have a transfusion unless they have severe clinical signs like impaired consciousness or laboured breathing. This means Janie does qualify, but is 20 mL per kilo enough? Most doctors believe the guideline is too restrictive.
So as a doctor, I felt that probably more volume was better.
When you see a very sick child, you see they're very anemic, the first thing you want to do is to correct that anemia, hoping that that will improve their outcome. But you don't know unless you do a clinical trial.
The TRACT trial asked 2 main questions about transfusions. One is whether 20 mL per kilo is enough blood for children like Janie, who qualify for a transfusion under current guidelines, or whether 30 mL per kilo would be better. Children often respond very quickly to a blood transfusion. Janie's sitting up and managing to eat something even before her transfusion is finished. During the trial, before knowing any results, the trial staff saw this and concluded more blood would be better.
When we give 30 mL per kg body weight, we see that the child's condition changes quickly. They improve quite quickly.
We thought probably 30 ml per kg was better than 20 ml per kg. That was the prediction during the trial.
So the results were a surprise. The outcome actually depended on whether the child has a fever or not. For those without a fever, the predictions that more blood would benefit were correct. At 28 days, only 3% of children given 30 mL per kilo had died, compared to 6% of those given 20 mils per kilo.
For those children who didn't have a recorded fever, 30 mils per kilo over halved their mortality compared to 20 mils per kilo.
But for those with a fever over 37.5, the extra blood was harmful. 5% of those given the higher volume died, compared to only 3% of those given 20 mils per kilo.
We found that for those who had a fever, a higher volume of 30 mils per kilo compared to 20 mils per kilo almost doubled their mortality.
I can't stress how unusual this is. So when we run these big trials, we look for lots and lots of different subgroups in whom things might work slightly better or slightly worse. And sometimes you can find that there is one group in whom something which is overall effective is a little bit more effective or a little bit less effective. But this isn't like that at all. This is completely opposite effects. 30 mils per kilo is better if you don't have fever, and it's actually worse, makes things worse if you do have fever. So it's the most extreme result I've ever seen.
We don't have an explanation. Those who didn't have a high fever when they came in, they probably might have just been coming in because they were very anemic, and they really just needed the blood. Whereas those who had fever, they had sepsis, severe malaria, and had lots of other infectious things that might have modified your response to the higher dose.
What we have is we have statistical confidence that these are not chance effects in either of the two groups, and we really have what would be called overwhelming evidence that the new intervention, more blood, is working differently in the two groups.
For Janie, who had a high fever, it means the current guideline of 20 mils per kilo is correct. But the large number of children who come in without a fever would benefit from bigger transfusions.
That is a landmark finding. It is going to challenge the way doctors treat patients. I expect a high level of scrutiny before acceptance. But I think the evidence that I saw is very strong and convincing.
The TRACT trial also looked at which group to transfuse. This 3-year-old girl is severely anemic with an HB between 4 and 6, but she has no severity signs. She's breathing normally and she's alert. At present, she does not qualify for a transfusion. But would she benefit from receiving blood? Children were randomized to receiving an immediate transfusion versus a triggered strategy, where they were monitored carefully and only transfused if their HB dropped below 4 or they developed severity signs. The results suggest waiting and watching is safe, as long as children really are watched.
Not immediately giving a transfusion is okay. It's that children survive as well as children who receive an immediate transfusion. But there is one caveat, is that you have to monitor children. By 48 hours, we had found that 50% of children had either dropped their hemoglobin to a very low level, which is a hemoglobin below 4, or they had developed severity features and therefore qualified for a transfusion.
Which is what happened a few hours later with this little girl. Her HB dropped further and her breathing became more laboured. So how practical would it be to implement the results of the TRACT trial? Would there be enough blood to increase transfusions for a significant portion of severely anemic children from 20 to 30 mils per kilo? Blood comes in set pack sizes. Usually children don't finish the whole pack and excess blood is discarded. So in many cases, giving 50% extra blood would not require starting a new pack.
I do not think that any increases in volumes of blood needed are going to be proportional to the increase from 20 to 30, because that proportionality assumes that we are using each and every drop of blood we collect now, which isn't the case.
The trial found that the strategy of limiting transfusions to 20 ml per kilo did not actually save blood. This was in part because many more in this group needed a further transfusion in subsequent days. So the 20 ml per kilo group ended up using as many blood packs as the group given 30 ml per kilo straight away. And there are other advantages for blood services in the trial's findings. In many cases, plasma is separated out from red cells. These are then packed separately in what's known as packed cells. Many doctors believe packed cells are better than whole blood. In fact, the trial found that whole blood is just as good.
That has important messages for the transfusion services because preparing components is costly and it's very time consuming.
So with the whole blood and the red cells, we keep at a temperature of 2 to 6 degrees.
Likewise, they found that blood, which had been kept for over a month, nearing the end of its shelf life, was just as effective as new blood. Finally, all the children were tested retrospectively for sickle cell, a hereditary illness which causes chronic anemia and is common in East Africa. 25% tested positive.
What's very important is that those children didn't have a different outcome or worse outcomes compared to children who had anemia from other causes, which means that we don't need to have a specific transfusion protocol for children with sickle cell disease. They can be managed without being immediately identified on the same protocol.
Some of the trial staff fear the hardest changes to implement may be the most simple ones. Close monitoring has been shown again and again in research to greatly reduce mortality in very sick children. But implementing it in overcrowded, under-equipped and understaffed health centres and hospitals has proved elusive.
There are structural reasons why it is not possible to always measure a temperature or to always measure hemoglobin in the ward. And I don't think those structural reasons will go all of a sudden just because there are results that show the importance of doing this. I think what will be needed is that some form of implementation research is done to see how those results that were achieved under very well conducted and well controlled study conditions can be implemented in practice where some of these things will not be there.